camera.
Okay, great. I'm getting the notice that we can go ahead and get started. It looks like we do have about 115 participants, and we'll expect to have more joining as we get going. My name is Ellen Eaton. I am an associate professor of medicine in the Division of Infectious Diseases at the University of Alabama at Birmingham. I am honored to be here with Dr. Chandler, who's at University of Washington in Seattle, and will be presenting on alcohol and tobacco use disorders in patients with HIV as part 4 of our IAS-USA MATE compliant training on substance use disorders. All right, just a little bit about the training. This is a requirement that DEA certificate holders complete CME training, up to 8 hours training specific to the management of substance use. And this is part of DEA registration and maintaining certification. So we're glad you're here to stay compliant. As you can see, we've had several sessions here, and this is the 4th one. You can also go back on demand to see prior sessions, and we hope you do. For those who aren't familiar, there is a National Substance Use Warm Line that is cost-free, confidential, that we encourage you to write down this number. Again, slides will be available after the presentation if you want to go back and use this warm line as a resource. And just a review of the content on the web board and their disclosures. Also, a summary of myself and our presenters, relationships with ineligible companies. As a reminder, this course does have 1.25 AMA credits associated for participation. It has been approved for up to 1.25 CME credits, and you can see a breakdown of the other credits you can receive for participation. And a list of our support from a range of supporters here. And lastly, for navigating this activity, for poll questions, you will see a separate window that will pop up for you to choose your response to the poll. Please remember to submit your questions using the Q&A button. That helps us keep things separate from a general chat and the poll responses. If we're not able to address all the questions, we'll try our best, and there's a chance we can address them in future trainings as part of this course. And the chat is open for discussion with other attendees. Okay, without further ado, I think we'll be switching over to hear our presentation. Again, thanks so much again, Dr. Chander, and we'll get going.
Great. I want to make sure that everyone can see the correct slide. Is that right? Okay. It's really my pleasure to be here today to talk to you about alcohol and tobacco use among people with HIV. We're going to start with a couple of polling questions just so I have an understanding of current practices. So when do you personally screen for alcohol use in your patients with HIV? At the initial visit, annual visits, every visit, or when alcohol use disorder is suspected? So we see many at every visit and some annually and some when AUD is expected. Okay. And the next question, how often do you ask your patients with HIV about alcohol use when they experience a viral rebound? Always, often, sometimes, never. Great, so about a third always, and then about a third often. Terrific. Okay, so let's get started. So what are our objectives today? So on completion of this 1-hour seminar, I hope that you'll all be able to describe the impacts of unhealthy alcohol and tobacco use on HIV-related morbidity and mortality, to implement optimal screening methods for alcohol and tobacco use in HIV clinical settings, and to list evidence-based therapies for alcohol and tobacco use among people with HIV. So we'll start with our first pre-test question. A 40-year-old cisgender man with HIV presents with an HIV RNA of 1,500 copies after being undetectable for the past 12 months. Screening with alcohol use disorders identification test reveals a score of 7. He smokes tobacco, but he has no opioid or stimulant use. In addition to expressing concern about his viral load and alcohol use, which of the following is the most appropriate next step? Assess for alcohol use disorder, prescribe naltrexone, prescribe disulfiram, refer to psychiatry for further evaluation. Okay, next question. A 25-year-old non-binary person was diagnosed with HIV 2 years ago on routine testing after presenting with a new STI. Their HIV RNA levels are persistently undetectable on lamivudine and dolutegravir. They smoke 1 pack of cigarettes per day for the past 8 years. On routine screening, they note they're interested in quitting tobacco use. Which of the following treatments has been demonstrated to have the highest quit rate among people with tobacco use disorder? Nicotine gum, lozenge, bupropion, varenicline, or nicotine patch? Great. So now we will get started. Let's see if I can advance. Okay, so what are we going to discuss today? We're going to discuss unhealthy alcohol use, the HIV care continuum and comorbidities, screening and intervention for unhealthy alcohol use among people with HIV. Then we'll move to tobacco use among people with HIV, and then management of tobacco use disorder in HIV clinical settings. And I realize this is a lot, so throughout the talk, I will be pointing to additional resources that are available. So I really want to start with just describing the spectrum of alcohol use among people with HIV and in the general population. So alcohol use really ranges from no use to lower risk drinking to at-risk use, which is defined by the NIAAA as greater than 4 drinks per occasion or greater than 14 drinks per week in cisgender men less than 65 years of age. And these are standard drinks. And in women and men greater than 65 years of age, greater than 3 standard drinks per occasion or greater than 7 standard drinks per week. And among transgender individuals, there is one study where they did validate different questions, and they found that greater than 4 drinks per occasion or an audit C of greater than or equal to 3 was a good screener for at-risk drinking. So as we move across the spectrum from at-risk drinking, people can develop alcohol use disorder, and that's mild, moderate, or severe. And where people fall on this spectrum really determines what treatment we will actually provide for an individual. And so it's important to really think about this spectrum. And not surprisingly, as severity increases and from at-risk use to alcohol use disorder, there are more consequences associated with unhealthy alcohol use. Some of these in HIV include interruption of the HIV care continuum, the steps necessary to optimize care of people with HIV, which if you look at the figure include linkage to care, retention in care, and viral suppression. Among people with HIV, unhealthy alcohol use occurs in about 27% of individuals. So these are data from the Veterans Aging Cohort Study, where the authors examined different levels of alcohol use based on the audit C, which we'll discuss later, and its association with key steps in the HIV care continuum. What you see is that higher levels of audit C scores, which again indicate increased alcohol-related problems or disease severity, was associated with lower engagement in HIV medical care, lower treatment with antiretroviral therapy, and reduced viral suppression. This has also been shown in other non-VA samples. In a sample in an urban cohort in Baltimore City, people with HIV with unhealthy alcohol use spent more time with a viral load of greater than 1,500. In a larger sample across several HIV clinics in the US participating in the CFAR network of integrated clinical systems, increases in drinking from abstinence were associated with a higher risk of viral non-suppression. And finally, in the Johns Hopkins HIV clinical cohort, among almost 1,700 patients in the cohort, 26% had an alcohol use disorder. And really, relative to person years in which people with an alcohol use disorder were not drinking, there was increased viral suppression during periods of time in people with alcohol use disorder when they returned to drinking. So these studies really all indicate that there's an increased risk of viral non-suppression among people with unhealthy alcohol use, particularly in the context of changes in use. This may be due to stopping antiretroviral therapy, resulting in rebound, or other adherence challenges, lack of prescription of ART. But regardless, this really presents an important case for screening for unhealthy alcohol use regularly in our patients, and remembering to screen even when a person stops drinking, because return to alcohol use can confer increased risk for viral non-suppression. And this is not to say that we shouldn't be treating all of our patients with unhealthy alcohol use with ART, because we absolutely should. It's just really being on the lookout when there is viral non-suppression for alcohol use. So finally, rounding out the HIV care continuum, I'm presenting data again from the CFAR network of integrated clinical systems across 7 HIV clinics in the US and among approximately 10,000 people with HIV. We looked at whether heavy alcohol use or unhealthy alcohol use was associated with lower retention in care. And what we found was that people with unhealthy alcohol use were 22% less likely to be retained in care. And individuals with heavy episodic drinking or binge alcohol use, and that's the greater than 4 or 5 drinks per occasion, were 10% less likely to be retained in care. Alcohol use, I think, as you all know, does not just interfere with the HIV care continuum, it's also comorbid with and complicates the management of many other chronic diseases, including mental health disorders, depression, anxiety, trauma, other substance use, opioids, stimulants, cannabis, tobacco use, co-infections, including hepatitis C, tuberculosis, and pneumonias, chronic diseases, which we increasingly manage in our HIV primary care settings, diabetes, hypertension, cardiovascular disease. I've often picked up alcohol use in people with prior alcohol use disorder when I've seen their A1C rise dramatically. Liver disease, cognition, and cancer, as you can see on the figure on the right of the screen. And mortality. There have been a number of studies among people with HIV demonstrating increased overall and liver-related mortality among individuals with HIV and unhealthy alcohol use. So given this, that among people with HIV, unhealthy alcohol use and alcohol use disorders are associated with lower use of medical treatment, poorer medication adherence, liver disease progression, mortality, it's really important to implement evidence-based alcohol treatment strategies in this population. Most people in need of alcohol treatment do not access subspecialty services for a variety of reasons, not being ready to stop, they can't afford treatment, they're worried about the negative impact on their job, stigma, they don't know where to go. So given these potential barriers to accessing traditional alcohol treatment services, integration of alcohol reduction strategies into HIV care and other clinical settings may increase treatment access and ultimately improve HIV treatment outcomes. So I'm going to bring us back to this spectrum of alcohol use. It looks a little bit different. I've presented it linearly here. But again, just to remember, when we think about alcohol use as on a continuum, where people fall on this continuum is going to determine how we what treatments we offer. So whom should we screen? All people presenting to care. We screen at baseline, and if negative, repeat at least annually, and if positive, at every visit. Sometimes we should consider screening if we see new viremia, viral rebound, transaminitis, changes in blood pressure, trauma, accidents, depression, anxiety, other mental health disorders, tobacco, and other substance use. So what should we use? So the NIAAA recommends a single question to start with. And so it actually makes it pretty easy. How often in the last year have you had 4 or more drinks or 5 or more drinks on one occasion? And if greater than or equal to 1, you follow up with quantity frequency questions. And we frequently use the alcohol use disorders identification test. I'm just going to quickly review a standard drink because I refer to it quite a bit. So in the US, a standard drink is any drink with 14 grams of alcohol. So that includes 1.5 ounces of liquor, 5-ounce glass of wine, 12-ounce can of beer. And I always remind individuals to ask specifically what someone is drinking because 40-ounce cans of beer are different from a 12-ounce can of beer. So just clarifying that. So the audit C. So there are 3 questions in the audit C that really address quantity and frequency of alcohol use. The first one is frequency. How often do you have a drink containing alcohol use? How many drinks do you have on a typical day? And then the third question addresses heavy episodic drinking. And a positive test is greater than 3 in cisgender women and transgender individuals, and greater than or equal to 4 in men. The audit C goes up to a score of 12, with higher scores really indicating increasing risk of adverse consequences from use. And we really, it's really important to use a standardized validated questionnaire and to really have people answer the questions really as they are written. And a lot of that is really related to, we're more likely to pick up alcohol use if we use a standard questionnaire. And we as providers and staff may introduce bias in how we ask questions when we sort of deviate from the set questions, and we may then not actually accurately assess alcohol use. So after an individual screens positive for at-risk alcohol use, it's important to determine where they fall on the spectrum of use. And many of you from the pre-polling question are aware of this. So we really want to know, do they have at-risk alcohol use only, or do they have an alcohol use disorder? So to determine this, you can use an AUD symptom checklist that goes through the criteria to determine if the person has any alcohol use disorder. And if yes, is it mild, moderate, or severe? And so here, mild is 2 to 3 criteria, moderate 4 to 5 criteria, and severe 6 or more criteria. And I always like to just add here, just as a reminder, that alcohol use often does not occur in isolation. And so thinking about screening for other comorbid mental health disorders and other substance use at the time. So what do we do after we determine that an individual has unhealthy alcohol use? So if you remember, based on the spectrum, we can start with a brief alcohol intervention. So this is recommended by the USPTF for persons with unhealthy alcohol use. It generally consists of 4 or fewer sessions and lasts 5 to 15 minutes. It includes non-judgmental normative feedback and advice to cut down or stop drinking. The advice is placed in the context of the person's recommended limits and their current health status. It can consist of components of motivational interviewing and addressing a person's ambivalence. There can be elements of cognitive behavioral therapy with goal setting and coping strategies. Evidence suggests that follow-up visits further enhance its outcomes. And in a 2018 review of brief intervention for unhealthy alcohol use, BI was demonstrated to reduce the number of drinks per week among persons receiving BI versus control, with 14% of more participants drinking below limits. So I have this up here because sometimes we say, oh, do a brief intervention, but then we wonder, what does that really mean? And the NIAAA has published recently some core resources that go through really how to deliver brief intervention. And they outline 7 steps. The first of which is really, and I'm just going to go through this very briefly. The first of which is asking permission. So start by setting an agenda to discuss alcohol use. If it's okay with you, I'd like to discuss your alcohol use. Giving feedback and advice. So based on their current screening, linking what you found to their current health, their physical health, their mental health, and then providing advice, noting that alcohol reduction may improve their current health. If they don't have an alcohol use disorder, you can recommend cutting down to safer limits below those NIAAA guidelines. And if they have an alcohol use disorder, really stating your concern, providing advice to reduce or quit, providing evidence-based interventions, behavioral health, potential referral. It's important to really check in and ask patients what they think of the information. Are they ready to change? Do they have any questions, any thoughts, so that you can dispel any potential misconceptions? Building motivation, so exploring reasons for making a change, asking an open-ended question. What might be some of the benefits of cutting back? Offering support, maintaining empathy, non-judgment. The person may not be ready to change, but at least you're opening a door to further communication, identifying next steps, and then following up and continuing the dialogue at the next visit. So what do we do after brief intervention? So really the evidence suggests that brief intervention may not reduce drinking in patients with more serious drinking problems. So really in the management of other chronic health conditions, such as depression, tobacco, opioid use disorder, medications can offer the next level of intervention. They can target neurotransmitters involved in the reinforcing and anxiolytic effects of alcohol use. They're beneficial in combination with non-pharmacologic therapy, including counseling and other behavioral therapies. There are currently 3 FDA-approved therapies, 4 medications: naltrexone, PO, and intramuscular, acamprosate, and disulfiram. Interestingly, data from the 2019 National Survey on Drug Use and Health suggests that only 1.6% of patients with an alcohol use disorder receive FDA-approved medications for alcohol use disorder. So there's a real treatment gap here and a real potential for us to make a difference. Okay, so alcohol really affects all the major neurotransmitter systems. It does stimulate dopamine release in the mesolimbic system, leading to pleasurable effects. The dopamine projects to the orbital frontal cortex and prefrontal cortex, which can regulate motivation, cognitive control. Important to note that it really interacts with all the systems. So we have the serotonin, dopamine, GABA, glutamate, acetylcholine, and opioids. So first I want to talk about naltrexone. So naltrexone blocks opioid receptors. So it attenuates the positive reinforcing effects of alcohol use. And there are a lot of data on naltrexone. It decreases heavy drinking days, return to heavy drinking, and decreases craving. It's an opioid receptor antagonist, and typically dosed either 50 milligrams daily or 380 milligrams IM every 28 months. There are side effects: nausea, vomiting, dizziness, headache, injection site reaction for those who get the shot. And it is contraindicated in acute hepatitis, liver enzymes greater than 3 to 5 times the upper limit of normal, or liver failure, people who are using opioids. So there are data. There's a very recent, hot off the press, systematic review and meta-analysis that was just published in JAMA. And really looking at the different formulations of naltrexone and found that any dose of naltrexone and PO naltrexone resulted in lower return to any drinking, return to heavy drinking, decreased percent heavy drinking days, and decreased heavy drinking. In terms of IM naltrexone, there were very fewer studies, and so they actually noted the strength of the evidence being low, though the for return to any drinking, the point estimate is below 1. And there was another recent meta-analysis of IM naltrexone that did favor extended release naltrexone for in reduction of heavy drinking days. So naltrexone among people with HIV. So what are the data? So for those of you who attended Dr. Springer's earlier talk, you were introduced to her study where they tested extended release naltrexone among individuals, incarcerated persons on release. And I will just very briefly note the end result, which was that individuals who were randomized to the IM naltrexone arm were more likely to be virologically suppressed at follow-up. This is a study that was done in the veterans aging cohort to look at hepatic safety of naltrexone among people with HIV. And I always find this to be a very important study because they examined AST and ALT after initiation of naltrexone, and actually found that there was very little transaminitis among people receiving naltrexone. And in the 2 cases where they were elevated, they actually came down upon cessation, really demonstrating that naltrexone is safe. And finally, in a smaller randomized controlled trial of naltrexone use among people with HIV, extended release naltrexone did reduce heavy drinking days. So I'm going to go back to this for a second, just to summarize, to say, I think we have very good evidence here that naltrexone is effective in alcohol reduction. So the next FDA-approved medication is a camprosate, this really restores the balance of excitation and inhibition of dysregulated by alcohol exposure. It reduces craving, and so has found to be effective in reducing return to any drinking. It works on the GABA system and decreases activity of glutamate. So the dosing is hard with this. It's 666 milligrams 3 times a day if someone has a normal kidney function, and it's reduced to 333 milligrams 3 times a day with creatinine clearance of 31 to 50, with side effects of diarrhea, nervousness, fatigue. We use this a little bit less here. Most of the trials that found that this was effective occurred in Europe, and we'll try it. It's just it hasn't had the same demonstrated efficacy, and I'm not sure why in US studies. And the third FDA-approved medication is disulfiram, which I know most of us have heard of. It interferes with alcohol metabolism by blocking acetaldehyde dehydrogenase. So alcohol is metabolized by ADH to acetaldehyde, and disulfiram blocks the ALDH metabolism. And so you get a buildup of this acetaldehyde, which is is toxic, and in the respect that it causes flushing, nausea, increased heart rate, sweating, dizziness, sort of some of the key things. If you look at the data from McFeeters on the right side of the slide, it actually doesn't look to be very effective in terms of return to any drinking. And what's been noted about disulfiram, because it's really an aversive therapy, is it tends to work if it's observed, if people are observed taking it. Otherwise, the trials tended to be negative. So it is contraindicated in patients receiving or using ritonavir liquid, metronidazole, alcohol-containing products, people with severe myocardial disease. And disulfiram reactions can occur up to 14 days after taking disulfiram if alcohol is consumed. And it can also occur with alcohol-containing tonics, mouthwash, cough syrup. So I'm just going to briefly, just on this table, summarize what was in the JAMA systematic review on non-FDA approved medications. So there's baclofen, which reduces return to any drinking. You'll notice it says evidence strength low. There's fewer clinical trials. It's often used in liver disease. Gabapentin reduces return to heavy drinking. And then topiramate reduces percent of drinking days, heavy drinking days, and drinks per drinking day with moderate strength evidence. And I think the major limitation with topiramate has been related to side effects, including paresthesias, drowsiness, and memory impairment. If you're interested in reading more about these, there's the McFeeters article, but there's also a very good summary of pharmacotherapies for alcohol use disorder treatments written by Hank Kranzler, and we can certainly get that reference out to all of you. So let's summarize, and this is directly from the NIAAA core materials. So what would we do in our practice? The step one is screen for heavy alcohol use using a brief validated screen. If they don't meet criteria for at-risk alcohol use, then generally we advise people on what the guidelines are and recommend that people stay within those limits. If they do have at-risk alcohol use, we assess for alcohol use disorder, get the typical drinking pattern, have them do an AUD symptom checklist. And then we go to a brief intervention. And if they have no AUD, really that's the advise and assist. You do the brief intervention, you ask permission to discuss alcohol use, give feedback, link your concern to medical problems, advise cutting down, check in, offer support, and rescreen at the next visit. And if they have an alcohol use disorder, similarly, you would discuss the alcohol use, giving a brief intervention, advise quitting, and discuss treatment options. And so those are going to be things like pharmacotherapy, outpatient treatment, depending on the therapy, build motivation. You're going to offer the behavioral support and pharmacotherapy, so it's just a little more intense, and then identifying next steps. And that's just to remember at the follow-up visits to revisit, acknowledge, affirm, and explore. So in summary, unhealthy alcohol use can interrupt steps in the HIV care continuum, complicate comorbidities and their management among people with HIV. Given the impact of alcohol use on HIV infection and comorbidities, and US goals of HIV treatment is prevention, it's really critical to initiate antiretroviral therapy among people with unhealthy alcohol use and address the unhealthy alcohol use. So universal screening with standardized tools can improve identification, and evidence-based alcohol reduction interventions can be implemented and may improve outcomes. So these are some of the resources I wanted to highlight. One is the IAAA Treatment Navigator, because often in practice, we're not exactly sure where we should send someone. And sometimes patients also just want a resource to know where they can go. And the Treatment Navigator, there's a site for clinicians and a site for patients where people can put in what their needs are, and they can help them locate different treatments. So I've found this to be very helpful. And the second on the right of the slide is the IAAA Core Resources, which is very nice. They're very quick modules that you can go through. You can get CME to really, just learn more about how to address alcohol use among your patients. Okay, so we're going to move to tobacco. So with highly effective and durable antiretroviral therapy, tobacco smoking really is, I would say, the largest, and I think many others, threat to the gains achieved through durable viral suppression. In a large cohort study of about 18,000 people with HIV on antiretroviral therapy across Europe and North America, individuals who smoked had nearly twice the mortality of those who did not, with significant mortality attributable to cardiovascular disease, non-HIV related malignancies. And then groups in the US and elsewhere have really tried to look at mortality attributable to smoking among people with HIV. And in the study on the left by Hellenberg and colleagues, what they really found was that all-cause and non-AIDS related mortality was substantially increased among smoking compared to non-smoking people with HIV, with a mortality rate ratio of over 4. And in the study on the right, a modeling study done by Krishna Reddy, they did a computer simulation of HIV disease and treatment and projected life expectancies of people with HIV based on their smoking status, and found that among people with HIV entering care at age 40 who continued to smoke tobacco, they had greater than 6 years of life lost. And so really it's just the gains that we achieve through antiretroviral therapy and effective treatment, are diminished by continued smoking, really making it critical to address in clinical care. And even really, quite importantly, tobacco use is highly prevalent among people with HIV. In a recent study using data from the National Health and Nutrition Examination Study, looking at smoking across different time periods from 1999 to 2016, they found most recently that the prevalence of smoking was 46% among people with HIV versus 25% in the general population. And if you look at the figure on the right, what you can see is the red indicates people with HIV, and the green is people who smoke without HIV. And it is decreasing in both groups, but it is really significantly higher among people with HIV. And not surprisingly, tobacco use is more prevalent among people with substance use disorders, mental health disorders, which also intersect with HIV infection. And people with HIV with tobacco smoking have increased risk of cancer, cardiovascular disease compared to those who do not smoke, increased tuberculosis risk, increased worse outcomes with that. But I think what's really important is with cessation, cardiovascular risk can be reduced and quality of life can improve. So let's talk about the approach to tobacco cessation. And it's somewhat similar to the approach to alcohol use. So the first thing is really to ask and document about tobacco use at every visit. Do you ever use or smoke a tobacco product, such as cigarettes? And it's really important to really get at some people don't smoke every day, but you do want to know that as well. Assess the history, the pattern, how long they've been smoking, prior quit attempts, number of cigarettes per day, days per week, prior treatments, and how soon in the morning do they smoke their first cigarette. And that's important when we start to think about how we're going to dose short-acting nicotine replacement therapies. And then the next step is advise. So advise in a clear, strong, and personal manner to quit use. Quitting smoking is the most important action you can take to improve your overall health. And the third step is assist, connect. So it's really advise, assess, ask, advise, connect, or ask, advise, assist, connect, with connecting to counseling and pharmacotherapy. Because in fact, really, combined treatment is actually superior to counseling or pharmacotherapy alone. You've probably seen this picture before as it relates to nicotine and other substances. So as we all know, tobacco cigarette smoking is chronic, it's relapsing. It often takes several attempts for people to quit tobacco use. When tobacco is smoked, it travels through the pulmonary venous system, through the heart, and directly to the brain, where it stimulates the nicotinic acetylcholine receptors in the brain, releasing dopamine, really, and then responsible for the pleasurable effects. There are other neurotransmitters involved, but dopamine neurons in the ventral tegmental area and the nucleus accumbens play a really large part in drug-induced reward. So nicotine causes both pleasurable effects and it can reduce stress. So the rewarding effects really become associated with certain situations and moods. So these become cues. They're called cues. So coffee after a meal, smells, tastes. So these situations and mood then can become triggers for smoking, as does withdrawal. So there's a couple of different things involved here. So there's the nicotine dependence, but then there's also these other components. So when addressing tobacco use, there's the nicotine dependence and the cues or conditioning that occurs. And thus, why this sort of two-pronged approach of behavioral and pharmacologic therapies tend to be superior to either alone. So, the approach to tobacco use, there are a number of evidence-based behavioral interventions for tobacco use. So there's a recent from 2021 updated USPTF guidelines on interventions, many effective behavioral interventions, individual counseling, group counseling, quit lines, proactive counseling, mobile phone-based interventions, video counseling. So let's move into the pharmacotherapy. So the pharmacotherapy for tobacco use disorder is really, it's to, one, address withdrawal symptoms that accompany cessation, such as irritability, difficulty sleeping, feeling down, cravings, headaches. These symptoms can be a huge barrier to the brain behavior changes involved when people are progressing to tobacco use disorder. But there are tools for easing the burden of these withdrawal symptoms, including varenicline, bupropion, nicotine replacement, and NRT and medications don't have the harmful effects of combustible tobacco cigarettes. So I'm going to just go through these different treatments so that we can just talk through them briefly. Oops. Okay. So nicotine replacement therapy, it's a full receptor agonist, reduces nicotine withdrawal when an individual stops smoking. So the nicotine patch is long acting. So it's a slower onset of action, and then you'll have basal levels, whereas the lozenge, the gum, the spray are short acting and have a rapid onset. So really combining these, using them in combination, where you have the sort of basal levels of nicotine from the patch, and then using the lozenge or the gum, et cetera, when there's an acute craving, because it has rapid onset, is really the ideal approach to using these. So really the data demonstrate that dual NRT is superior to single NRT. In a recent review, the same one I cited on the prior page, dual versus single NRT was associated with a 1.25 increased risk of tobacco cessation compared to single. That's not to say that single NRT isn't effective, though. And so the second row on the table demonstrates single NRT versus placebo or no drug, also demonstrating its effectiveness. I think we're all familiar with the patch, so I'll just go through very briefly that there are 3 doses. Use a higher dose for more cigarettes smoked per day. You can use it for greater than 3 months, and after 6 weeks, when we reassess folks, you can continue at the original dose or taper to a lower dose. Sorry, I was having trouble advancing. So the lozenge and the gum, I find clinically, for me, this is where I need to spend more time really discussing how to use these with my patients. So they come in 2 or 4 milligrams. Your dosing is based on how soon after they have their first cigarette in the morning after waking up. So if it's less than 30 minutes, usually start with 4 milligrams. And if it's greater than 30 minutes, it's 2 milligrams. So for the lozenge, the key is to place between the gum and the cheek and let it melt slowly, and no food or drink 15 minutes before or during use. People can have mouth irritation, hiccups, heartburn. And for the gum, similarly, I hear from a lot of my patients, so it didn't work. And when I explore how they used it, they were chewing it. So what we spend some time on is explaining you chew it briefly and you park it inside your cheek, and then discard after 30 minutes. And again, the no food or drink. And so that is where I have found that I needed to spend time, which I used to not do. And then as I started to explore how people were using the shorter acting, I realized that it was more effective after I discussed use. The nicotine inhaler is prescription, as is the nicotine nicotine nasal spray. So, but on this slide are instructions on how you can use it. I failed to mention, but it's on this slide above, that these details are all very nicely detailed in a review article by Dr. Nancy Rigotti that came out in the last year and a half. The reference is on the very first slide. Okay, so varenicline. This is a nicotinic receptor partial agonist. It reduces withdrawal symptoms through its agonist effects and blocks the rewarding effects of smoking through its antagonistic effects. There are data for its efficacy among people with HIV. There was a large randomized trial in France, and where they found that varenicline was safe and resulted in a higher rate of continuous abstinence, 18% with varenicline versus 7% with placebo. And in the United States, there was a randomized trial among people on antiretroviral therapy, and they found a higher 7-day point prevalence abstinence at 12 weeks. They did find that the effect diminished by week 24, but adherence was really correlated with tobacco cessation. This is a recent Cochrane review from 2023, which really reviews. I created this table just to really summarize the evidence on varenicline compared to the other treatments. So varenicline versus placebo is associated with twice the risk of tobacco cessation. Varenicline versus bupropion also increased tobacco cessation with varenicline versus bupropion. Varenicline versus NRT increased tobacco cessation. These are all with very high certainty evidence. And then varenicline versus dual NRT is about the same. They're equivalent. The lower evidence is based on the fewer studies, but they look to be equivalent. So how are we going to use this? Again, it's you up-titrate the dose over 1 week. The dosing here is just for your reference. You can start 1 to 4 weeks before the quit date. But the other way you can do this is actually by having the person gradually reduce their smoking while they're on the medication. I've actually done this quite a bit in my clinical practice to work with people on cessation. So they start the medication and they reduce their smoking by 50% by week 4, another 25% by week 8, and quit by week 12. And you can use it. So duration is 3 to 6 months, and longer durations have demonstrated safety. And there are common adverse effects that we do hear from our patients: vivid dreams, headache, insomnia, nausea. So what about mental health? You know, there was a lot of press about varenicline when it came out and concerns about the neuropsychiatric safety. So the EAGLE study was a big study that came out. Now it seems like it was very recent, but it turns out it was actually not as recent, about 5-6 years ago, 2016. And they looked at the neuropsychiatric safety and efficacy of varenicline, bupropion, and the nicotine patch in people who smoke with and without psychiatric disorders. And they included people with stable psychiatric disorders. And there was no significant difference in neuropsychiatric adverse events between those who received varenicline and any of the other medications. And they also demonstrated in the study that varenicline was superior to bupropion and the nicotine patch. So I think in summary, you know, we can use varenicline, and it is considered first-line therapy. So bupropion reduces nicotine withdrawal by inhibiting reuptake of dopamine and norepinephrine, stimulated by nicotine binding to midbrain neurons. Same Cochrane review demonstrated effectiveness of bupropion versus placebo, but it was not, it was actually inferior to dual NRT. And this is just for your reference in terms of how to dose it, starting 1 to 2 weeks before the quit date, and the common adverse effects, and remembering the contraindication in seizure disorder. Okay. So I'm just going to take a second as we sort of round out. We're almost done with the core content. We talked at the beginning when we were talking about tobacco about kind of also the need for behavioral treatment. So I wanted to talk briefly about positively smoke-free, which is a behavioral intervention built on social cognitive theory, designed specifically for people with HIV. It's an 8-session format, and it's delivered in many different ways: live group therapy, individual therapy, a static website, smartphone, positively smoke-free on the web. This is all work done by Dr. John Shooter, who kindly shared his slides with me for this. So positively smoke-free on the web, and I'm focusing on this because this actually is going to become available for free on the web, was a randomized controlled trial of smokers, with people with HIV who smoked, who got the web-based controlled intervention. They got positively smoke-free on the web versus a web-based controlled AHA getting healthy intervention. And they had 506 participants from New York City and Baltimore. And everyone was offered 12 weeks of nicotine patches. The study primary outcome was confirmed 7-day point prevalent abstinence. And what they actually found was that positively smoke-free on the web actually did result in significantly increased smoking cessation compared to the American Heart Association attention control. And given that this, I know not everyone has web access, but this, I think, will be an upcoming resource that we can potentially connect people with web-based access to. So let's briefly summarize what we've discussed with tobacco use. So this is a nice figure from a nice, really great paper written by Krishna Reddy and colleagues that was in Clinical Infectious Disease, that really is a guide for clinicians how to manage tobacco dependence among people with HIV. And so the first thing is ask about tobacco use during clinical encounters. As we talked about, do you ever use or smoke tobacco products such as cigarettes? Deliver clear advice to stop tobacco, focusing on the benefits of cessation. So they give a couple of examples. While we're controlling your HIV, quitting smoking is the most important thing you can do to improve your health and live longer. I can help. Quitting smoking will help you get the full benefits of your HIV medicines. Quitting smoking will reduce the health risks of secondhand smoke for people and pets around you. Or you can show how quitting reduces cardiovascular risk using the ASCVD risk estimator. And then to prescribe pharmacotherapy and directly connect to behavioral therapy. So varenicline is considered first line, followed by dual nicotine replacement therapy, and then bupropion or single NRT. And then they list some behavioral treatments, including calling the quit line, 1-800-QUIT-NOW. There's text message-based counseling, in-person individual counseling, and then internet-based, becomeanx.org or smokefree.gov, where there are evidence-based resources. So I'm going to spend the next minute talking about lung cancer screening. So lung cancer screening is prevalent among people with HIV, and screening for tobacco use and providing evidence-based tobacco cessation treatments are really an excellent time to screen for lung cancer as well. So what does the USPTF recommend? That all adults aged 50 to 80 who have a 20-pack year smoking history and currently smoke or have quit within the past year be screened for lung cancer with low-dose CT annually, with stopping the screening once a person has not smoked for 15 years or has a health problem that limits their life expectancy. And how do they recommend implementing this intervention? Assessing for pack years, and then if the person does meet criteria, they really recommend engaging in shared decision-making to talk about the potential benefits and limitations and harms. And then if they are amenable, referring them to low-dose CT, and then also concurrently advising them to quit smoking and offering them evidence-based smoking cessation interventions. Okay, so these are some, I think, good resources also for more information. So there is an online module for smoking cessation in people with HIV. At the bottom is the article by Reddy and colleagues on tobacco use and treatment of tobacco dependence among people with HIV. That's a practical guide for clinicians. And then becomeanx.org. So in summary, tobacco and alcohol use disorders are prevalent among people with HIV and are modifiable barriers to health outcomes among our patients with HIV. Evidence-based treatments are effective in reducing alcohol and tobacco use. Routine screening, providing non-judgmental advice, and connecting to care via pharmacotherapy, referral, linkage to behavioral treatments, and additional resources are an important aspect of HIV primary care. So we'll go to our first post-test question. Okay. Let's see how you all did. So 86% of you said assess for an alcohol use disorder, and that actually increased from the first question, first time around. And okay, so this patient, I think, as you all saw, should be assessed for alcohol use disorder. The audit C is scored on a scale from 0 to 12, with scores of 0 reflecting no alcohol use. And in cisgender men, a score of 4 or more is considered positive. And for women, 3 or more, and transgender individuals. Follow up a positive score with the DSM-5 checklist or other assessment of AUD will determine whether the individual has AUD and whether it's mild, moderate, or severe, and will guide how we address alcohol use in the individual patient. Okay, second question. I can read it, but 25-year-old non-binary person diagnosed with HIV 2 years ago. They've smoked 1 pack of cigarettes per day for the past 8 years. They note they're interested in quitting. Which of the following treatments has been demonstrated to have the highest quit rate? Great. And again, much higher than the first time around. The correct answer is D. Really, meta-analysis of randomized trials demonstrates the superiority of varenicline over these other tobacco treatment options in achieving cessation. So I'm going to stop sharing and we'll take questions.
Wonderful. Thank you so much. We have a lot of great questions. Before we get started, I wanted to just remind the group that joined late that these slides will be available. So I see some questions about references and clarifying the data. These will be available online within 24 hours. And then Dr. Chander, were there any questions that came to you ahead of the session that you wanted to address, or would you like me to just read off what's coming to us live today?
Why don't we? Oh, thank you. Sorry, I did. Oh, I'm just looking at the questions. I apologize. I'm like, oh, I left out a reference. So we'll make sure if so I'm looking through the questions, and one is, can we add the reference to Hellenberg? And I'll make sure that the final slide set that anything that may have accidentally been missing is there. So just to address that. Okay. Yeah, I think we can go ahead and just go through the questions. Does that sound good?
Yeah, sounds great. I wanted to start with one that comes up a lot for me, around nicotine overdose in a patient who is maybe on a patch with or without a lozenge or gum. And they often ask, what if I smoke? Am I going to overdose? And how do you approach that patient?
Yeah, so they're unlikely to overdose. And I think when people are smoking with the patch, I sometimes ask myself, is the patch dose high enough? Right? Or are they using the lozenge or the gum correctly? So I think it's sort of, I try and reassure that it's, you know, do you need a higher patch? Are you using the treatments correctly? I may spend some time reviewing how to use them in the clinic setting. But I think we used to be told, oh, you absolutely cannot smoke if you have the patch on. And it actually, as it so happens, that it's probably going to be okay. And it's probably just a situation where we should be determining, are we actually under treating the person? I hope that was cool.
Yeah. And any concerns about duration? I know you mentioned 3 months is fine. Someone here asking, what about for years? They have patients that when they try to discontinue the nicotine patch, the patient then starts using again. So like chronic use and safety.
Well, I think that's safer than actually smoking combustible tobacco cigarettes. So I would say that that's a you know, a harm reduction principle, because you know, combustible tobacco cigarettes are worse for you.
Great point. In terms of the alcohol use disorder, someone asked about supports, specifically Alcohol Anonymous was not mentioned. Do you have thoughts on that?
So I do have thoughts. I think AA works very well for certain individuals. I think mutual support is actually can be quite helpful, and it's really about a menu of options and what works well for an individual. So I'm sorry I didn't mention that. So by its very nature, Alcoholics Anonymous is anonymous, and so you know, this sort of classic, can you do an RCT? You know, in a group where the principle is anonymity, is you know, it can't really be done. But it you know, there are data that show that it is effective for, you know, specific individuals. And I think my approach to this is one size doesn't fit all. So what is going to work for one individual may not work for another. And so it's really understanding what your menu of options is, given where you are. So I apologize for neglecting to mention that.
Great. Another alcohol use disorder question. Someone asked around risk reduction when the goal, either the patient or the provider, is just to reduce from, they give the example, a pint a day down to less, maybe once a week. What is the role for pharmacotherapy in that patient and goal?
Yeah. So you can absolutely, I mean, in some people, they receive naltrexone and they take it every day and they reduce their alcohol use. So really, there's really a move towards moving away from this idea of the requirement of abstinence, meaning that you're actually, you know, doing okay. So it's sort of, you don't have to be abstinent to be in recovery. And so if you can reduce to safer levels of use, that is great. And so some people use naltrexone for that. You can't use disulfiram for that. But so I think that there's absolutely a role for that. And it's really, you know, again, this really comes to sort of personalization. So some people may be able to reduce to, you know, from a pint a day, or let's say 4 glasses of wine every other day, to 2 glasses of wine every other day. And some people really may not be able to, you know, and there's a lot of factors involved with that, genetics, environment, et cetera. So But I think so much of this is meeting a person where they are and then working with them to determine what is the right goal for them.
Yeah, great. Very similar themes to in my opioid treatment clinic, right? You know, meet the patient where they are. The best treatment is the one that they're willing to try and adhere to. So similar themes. A question about the frequency of follow-up visits. I love this question because it's just a very practical, you know, for me as an HIV provider, say I want to initiate a patient on naltrexone, and I personally think I would need follow-up visits just to address that, rather than integrated 6-month visits. So what would you recommend for me in that situation?
Yeah, so I like to see people back. So the idea is really like we should see how they're doing. I might say 4 to 6 weeks, but depending on the person, maybe it's 2 weeks. I mean, but and then it's, you know, how are they doing? So are they taking the medicine? How, you know, have they had any adherence challenges? What have the side effects been? And then really sort of thinking through like, you know, have we given this current medication a fair enough shot? If they're still drinking at the same level, or should we wait another 6 weeks? Some of it's a little nuanced. And then do we need to actually step up their care because actually what we've given them isn't quite enough? And so I do think that sort of reassessment to determine if how someone is responding to a current therapy. So it's sort of like we initiate antiretroviral therapy and we see someone in a month to see how they're doing. I think maybe I would conceptualize it similarly, or starting a new diabetes medicine. You know, how are you doing? And then figuring out, you know, do we need to intensify care or is this stable? But I wouldn't wait 6 months to a year.
Great. Okay.
I did see, oh, I'm sorry to interrupt. I just wanted to answer this very quick question. It says, what is combustible tobacco? So that's just smoking a cigarette for, you know, so, and that's different, you know, like an e-cigarette doesn't have all of the sort of other chemicals that like your traditional sort of tobacco cigarette, you know.
Great.
Sorry, Ellen. I just
No, that we'll stick in that question area around smoking risks in people with HIV versus those who are not living with HIV. Is it more harmful in those with HIV?
Yeah, I believe it is believed to be so. And I'm hedging a little bit, but I actually am fairly certain that yes. I actually can't remember the data, and I apologize. So
I'm not an expert on this, but from the literature I'm familiar with, the answer is yes as well.
Yeah.
Great. And then a question around marijuana. I'm going to reframe this because I know we don't have time to do a whole section on marijuana for this talk, but a question around alcohol use and marijuana. And when you screen for alcohol, do you also screen for marijuana? And I guess that begs the question, do you treat a patient with a certain audit C-score differently if you know they are also using marijuana or not?
No, I mean, we'll try to, you know, address dual use, but we still should address the alcohol use. So I don't really, you know, again, it's always about meeting someone where they are, and maybe they're willing to reduce their alcohol and not their marijuana use, or vice versa. But I do think it is very important to dually screen. And then if we can address both at once, that's great. If someone says, I just want to, you know, reduce my alcohol use, you know, we can work with that.
Great. And this question came at the very beginning when we were talking about alcohol use and audit scores in women and some data relevant to women over 65. Is the risk of alcohol use greater in that group relative to those who are under 65? Does it matter?
You know, it is so interesting that you asked that. So here's what I'm going to say. I'm going to say, yeah, I believe so. And I don't know that we have the data, but yes, I mean, I think that would sort of make inherent sense if we're reducing the levels in older men, that we would presumably also be, you know, thinking about the same thing. But I don't know the data on that.
And I am obviously not an expert either, but just thinking about my patient population, the women who are over 65 are dealing with, who drink heavily. I'm seeing a lot of nutritional issues, bone disorders, frailty. Yeah, that's what I see clinically. And that group is also very hard. A lot of them have drank this amount for a long period of time. So I see a lot of resistance to treatment as well in women who have had heavy alcohol use for 20 years, for example.
It's very hard. It's very hard. So yes, I don't know the data, and yet it sort of seems to make clinically sense that we would be recommending lower levels.
Yeah. Could you comment on chewing tobacco in people with HIV? And I know that's also a big topic, but that's our one of our last questions that came in.
Yeah, I'm thinking about that. It's so interesting because I don't think I have ever treated that in my practice, because I don't think I've ever seen anyone with it. So it's a great question. And I guess what I would say is that, yes, absolutely, we should encourage cessation. And we could consider using similar, nicotine replacement or as a potential modality. But I that's about as far as I can go with that.
Yeah, and even though I live in the Deep South, I actually don't recall the last time I had a patient who chewed tobacco. It's something about this demographic. There's a lot of combustible, but yeah, great question. A question that just came in, we'll make this the last question. Any thoughts on naltrexone in patients with kratom use, underlying kratom use? And
I actually don't know. Yeah. I don't know if you know, Ellen.
I do not. This is one of those newer drug trends, illicit substances. We don't have a lot of it in Birmingham in our population. We don't specifically screen for it. We do periodically hear one of our patients is in the ER and that they, either inadvertently or intentionally tried some, but we don't see a lot of that. So don't have any thoughts on that. Okay, I think we got through the questions. I think I tried to type some responses. Some of them, I'm not sure, the responses go away on my end, so I'm not sure if they were delivered. But great job. Oh, Sandy, thank you, Dr. Springer, for answering them. Just a few reminders, housekeeping, how to claim CME. Again, these will be emailed by 5 p.m. tomorrow. We really appreciate your feedback through evaluations. Also a reminder that we do have emails that come through IAS-USA. Please register. Upcoming substance use disorder talk featuring Dr. Springer, Dr. Shoptaw. This is going to be a great overview of stimulant use, which we have really limited options in treating. So we'll talk about harm reduction, contingency management. Hope to see you December 20th for that next in the series. A reminder about the DC virtual course on emerging challenges in HIV medicine, also in December. Also, a great panel including Mike Sag, a podcast, Mike Sag, antiviral podcast with a special guest, Dr. Fauci, that you all probably recognize here. A long COVID webinar coming up in January, really important information for us. And thank you all for participating. Please complete your evaluation. We listen to those, we read them, we adjust our content accordingly. So thank you for participating. And to our excellent speaker, Dr. Chander, thank you so much. I learned a lot. I know all of us did. So we appreciate everything you put into that presentation.
Are we off camera now? Are we still?
You're off of the web, yeah.
Okay, I'm like,
oh, great. How did you know that? How could you tell we were off?
Oh, well, maybe I'm wrong. Am I wrong?
I don't think we're off.
Oh, okay. Hi, everybody.
That was great. Thank you, Dr. Chander. I learned a lot.
I did have one question for you all, but I'm kind of like waiting for everyone to disappear. But I'm not